It looks like a dominant, autosomal dominant.
Autosomal dominant. Good job. Excellent. Do we all agree?
Yeah.
So the parents are affected, right? The parents are affected. Yep. So it is a autosomal dominant. Do I need to know the examples of autosomal dominant inheritance? Yes, right? So look at the examples of the diseases, right? Tell me something that you've discussed. Did you talk about ADPKD, autosomal dominant polycystic kidney?
No.
Achondroplasia?
Yes.
Yes, we did.
No.
So what is
we have
achondroplasia?
achondroplasia.
We did.
So what is achondroplasia?
So you know that family rule. Did I tell you the little family?
It's basically dwarfism.
Yeah, it's a gain of function mutation that causes a early termination of the bone growth, so that you have shorter stature and several other things.
Good job, good job, very good. So achondroplasia, you have your FGFR3 mutation, fibroblast growth factor receptor gene, okay, for your achondroplasia. Think about Tyrion Lannister in Game of Thrones for achondroplasia. You have short proximal muscle, so you have short limbs. So I have a question, guys. Why do you have short long bones? However, your skull, you have a normal size head.
It's because the problem is in the epiphyseal plates of the long bones. So when you do endochondral ossification, it's not going to be as bad as it is when you have the epiphyseal plates on the long bone.
Excellent. There are two kinds of ossification. You have endochondral ossification and membranous ossification. Endochondral ossification is usually seen in your appendicular skeletons, your legs, and your arms. In achondroplasia, you have a defect in your endochondral ossification. The epiphyseal plates, they are closed earlier in life, therefore they are not growing. However, you have a normal skull. Why? The skull is formed via membranous ossification, meaning it doesn't need chondrocytes, right, to lay that layer. So you need to have chondrocytes first in order to develop bone. You're going to learn this, I think, next module. In the skull, you don't need those chondrocytes as a framework to build bone. That's why you have normal size skull. That's achondroplasia. How about we talk about Marfan syndrome? Ehlers-Danlos. Did you talk about this?
No.
No.
No, we haven't covered it yet, but it's a collagen issue, right?
Excellent. What kind of collagen?
Type 1 collagen?
Careful.
Yes.
Reticular?
Excellent. Good job. So you have what kind of collagen? Type 3 collagen, right? So you have 4 types of collagen. 1, 2, 3, 4. Type 1 collagen, it can be found where? Think about the K-pop group BTS. Bone, tendon, skin. For type 1 collagen, think about BTS, bone, tendon, skin. Type 2 collagen, think about the eyes. You have your eyes for type 2 collagen, right? Type 3 collagen, think about reticulin. Reticulin, which can be found in your blood vessels. So this is a defect of your Ehlers-Danlos. There are 2 types of Ehlers-Danlos, type 3 and type 5. Type 5 is you have a defect, you have hyperextensibility of your joints, you have hyperextensibility of your skin. Type 3 defect is much more deadly. Why? Because you might have aneurysm. You might die with aortic dissection because you have a defect in your reticulin. And type 4, 4, can be seen in your basement membrane. So that's your 4 type of collagen. Good. How about von Hippel-Lindau disease?
No, we
No?
haven't seen.
NF1 versus NF2?
Yes, we covered neurofibromatosis.
All right, could you tell me the difference between NF1 and NF2? What's the main difference? In the
We didn't
vignette?
get into that level of granular detail. That's
We
all.
only talked about neurofibromatosis in itself, not one.
Correct.
We only talked about type 1. We didn't talk
Could you
about
describe me? Okay, could you describe me then neurofibromatosis type 1. How do I know that the patient has neurofibromatosis type 1?
So really, with neurofibromatosis, they only talked about how it has different expressivity.
Uh-huh.
So that was a really focus, like that it can be like having like that different variable expressivity because it has different severity for different patients. Like sometimes it's cafe au lait, sometimes it's an actual lumps showing up on the skin.
That's actually a good description. Thank you for that. So you can have cafe au lait spots. You can also have something in your eye. We call this Lish nodules, right? You can have neurofibromas. You can have benign tumors for this one. Okay, so that's neurofibromatosis. In the vignette, if they say cafe au lait, you think neurofibromatosis. One, if they say Lish nodules in the eye, and you have brownish red spots in the eye, in the iris, think Lish nodules. If in the vignette it says skin tumors, you call this one neurofibromas. Think about neurofibromatosis type 1. The difference between type 1 and type 2, only in type 2 you have bilateral schwannomas, okay, which affects your cranial nerve number 8. Okay, good, very good. Next. Do I need to know the diseases? Yes, please. Please know the diseases. Leaf-Romany? Did you talk about Leaf-Romany? No?
No.
Okay, never mind. So know the diseases that you already know for each, if it is autosomal dominant or recessive, okay? Know the examples of each, know the signs and symptoms of each. Okay, this one, look at this. Look at this pedigree. And what do you think?
Autosomal recessive?
Autosomal recessive.
Oh, are you sure about that? Why do you think it's recessive?
Well, the affected person.
Because of consanguinity.
Yes.
Okay, good job. Again, what else?
There's no
And
vertical
it's a horizontal inheritance. And there's skipping of groups.
Excellent. So this is actually, you're right, autosomal recessive. Now, do I need to know the examples? Yes. Cystic fibrosis. Did you talk about cystic fibrosis? They love this.
Yeah.
Yeah, we covered cystic fibrosis.
Okay, now let's do some pathology. What's wrong with cystic fibrosis?
NF1 CFTR mutation.
CFTR gene receptor, right? There's something wrong with your CFTR gene in your cystic fibrosis, which leads to what? What mutation in the amino acid?
Phenylalanine 508.
Excellent. Phenylalanine delta 508. So why is the baby salty?
That's dealing with the epithelial, the lack of reabsorption of chloride back into the skin cells. So the sodium and the chloride also maintain at the skin level. So whenever the mom kisses the baby, you can taste the saltiness.
Very good, very good. Because the CFTR receptor has different functions in the lungs and in the GI versus the skin, right? In the lungs and in the GI, what's the function of your CFTR receptor?
Secretion.
Secretion, right? So it blocks that. So what happens? Sodium and chloride cannot be excreted. Therefore, what happens with the water?
It's not in the
lumen,
so you
right?
end up with
so you have what?
Dryness and thicker mucus.
Very good. So you can have dry mucus, you can have coughing, right? Contrast that with the function of the CFTR receptor in the skin. What's the function? It's a different one. Reabsorption of your chloride. And you're blocking that one, so chloride stays outside of the cell, right? Therefore, the baby is salty. It complexes with your sodium. Sodium in Cl is high outside of the cell. Okay, so that's why the baby is salty, because there's a different function of the CFTR. There's also cystic fibrosis. Don't forget, it can also affect your pancreas. So sometimes they can have malabsorption. They cannot absorb fat-soluble vitamins, your ADEC, your vitamin A, D, vitamin E, and then vitamin K. They have malabsorption syndrome. They can have steatorrhea. They can have fatty stools for your cystic fibrosis. What is that test that you do? I think
Is
it's
it
in the
the
lab.
chloride test or?
Exactly. You have the chloride test. You can also do the transepithelial, the nose transepithelial nasal test. I think it's one of the small groups that you had for cystic fibrosis. You can also do that, the transepithelial difference in your nasal cavity for your cystic fibrosis. Cystic fibrosis is very high yield. What chromosome is involved in cystic fibrosis?
Chromosome 7.
Exactly, chromosome 7. So you have chromosome 7. For Prader-Willi and Angelman syndrome, what chromosome is affected? 15. Excellent. So you have chromosome 15. So we talk about CF, that's high yield. Know everything about CF, okay? Talk about PKU, autosomal recessive PKD, you never talk about that. Hemochromatosis, did you talk about this one?
Yes.
Yes.
Yeah.
So what is hemochromatosis? Tell me. Volunteer.
An iron overload disorder.
Exactly. Iron, you have increase in iron overload. What can you see in the liver? If I biopsy the hepatocytes, what can I see?
Hemosiderin.
Hemosiderin deposits. You have hemosiderin-laden macrophages in your hepatocytes. What condition can cause hemochromatosis? So you have iron overload.
Iron deficiency, anemia.
Careful. This is overload of your iron. All right. So for hemochromatosis, what conditions predispose you to hemochromatosis? Anyone? Iron overload. So think about those who has thalassemias, beta thalassemias, who has sickle cell. Why? Because you commonly give them blood, right? You give them blood. So there is a probability, there's a high chance you're transfusing blood to them, that they can have hemochromatosis. Why does a woman have a decreased risk of hemochromatosis?
Due to menses.
Excellent. High yield because of menstruation. They lose blood, so they lose some of the iron in their blood. What vitamin is associated with increased iron reabsorption? Which is also used in hydroxylation of your proline and lysine residues in collagen synthesis.
Vitamin D.
Vitamin C. Vitamin C for your hemochromatosis, increased reabsorption of iron. So if you're having iron supplementation and taking vitamin C, there's an increased risk of you having iron overload. Okay, so thalassemia, sickle cell anemia. We're good so far. Here is another slide. Know the diseases, no signs and symptoms. We talk about Cartaginer. We talk about PKU. The opposite of hemochromatosis is Wilson's disease. This is copper. Increase in copper for your Wilson's disease. Did you talk about this one or no?
No.
No. Okay. Never. I won't bore you. Look at this image.
It's Y-linked.
Careful.
X-linked.
Dominant or recessive?
Dominant.
Careful. Are you sure? Guys, look at the pedigree analysis. I'm not gonna give you the answer, okay? What is the answer? X-linked, right? You said X-linked. Okay, is it dominant or is it recessive?
Recessive.